On behalf of the Department of Oral Pathology at SRM Dental College Ramapuram, I take immense pleasure in extending a warm welcome to the guest speakers of today's webinar, Dr. Robby George, Dr. Shilpa Singh, and Dr. Junad Khan. In the first place, I would like to thank you for having accepted our invitation to conduct this webinar. Coming to today's topic, orofacial pain, we as dental surgeons know that pain is the most common symptom which make people come to us for treatment. Diagnosing the origin of pain becomes more important as the treatment differs. Most of the time, the pain that we come across is odontogenic in origin and is usually either pulpal or periodontal in nature. But sometimes we do come across pain which is non-odontogenic in origin and which can mimic odontogenic pain. Identifying these painful conditions can be challenging to us. Our eminent speakers today are going to discuss about these types of pain in the orofacial region with various clinical case scenarios, which I'm sure is going to be interesting and informative to all the participants. I now request Dr. Dinesh Kumar to introduce the speakers to the participants.
Thank you, sir. It gives me immense pleasure in introducing the participants for the day. So Dr. Robby George, attendees, most of you would know he is my batchmate. Dr. Robby George is a clinical assistant professor at the Department of Orofacial Pain and Tmj Disorders. Dr. George has a dual appointment at the Department of Community Dentistry at Eastman Institute for Oral Health, University of Rochester. He had completed his clinical training in orofacial pain, followed by infectious disease and diagnostic sciences. After this, George completed his residency in pediatric dentistry. His current interest in research is Tmj disorders in pediatric patients and chronic pain and HIV patients. Welcome, George, for this extreme gathering. And Dr. Shilpa, so Dr. Shilpa, once again, a warm welcome to you. Dr. Shilpa is an assistant professor at the Department of Orofacial Pain and Tmj Disorders. She has a dual appointment at the Department of Community Dentistry at Eastman Institute for Oral Health, University of Rochester. She is an alumni of the Advanced Standing Residency Program of Orofacial Pain Program and Tmj Disorders at Eastman Institute of Oral Health. She holds a master's degree in health professions education. Her clinical focus is chronic orofacial pain and sleep disorders. She is actively engaged in both clinical and basic science research. Her area of interest in research is pain modulation and chronic pain. Welcome, Dr. Shilpa. And last but not the least, Dr. Junad Khan is a famous personality in the University of Rochester. He is the course director for orofacial pain. Dr. Junad is an associate professor and director of orofacial pain and Tmj disorders at Eastman Institute for Oral Health. Dr. Khan's clinical focus is in the area of orofacial pain and temporomandibular disorders. Dr. Khan serves on various university, national, and international committees and is involved in funding for industry research and service grants. Dr. Khan is actively engaged in both clinical and basic science research, and his areas of research include neuropathic pain, pain modulation, drug development, pharmacotherapy, acute and chronic orofacial pain. Guys, welcome to the program, and the stage is yours. Please take over.
Thank you, doctors, for the introduction. I think I will request everyone to mute so there's no echo. We spoke to Dinesh, I think, a week or two ago, and we had decided to basically pursue this venture together. I think it's important for many reasons. Number one, we as dentists do have a role that we have to play, not only in pain, but understanding the complete picture when it comes to a patient. We can't cover everything in this presentation as it's too much to go through, but we'll try to give a little bit of brief orientation and add a little flavor with different cases that we have. And then we'll open it for discussion. Typically when we lecture in a way where it's more engaging. Unfortunately, with the things going on in the world, we can't have this, but if you have questions, please make sure you type them up in the chat with Dr. Dinesh. He'll let us know and we'll try to answer as much as questions you have. If there are any questions that you think are important or you need to know besides the topic, in regards to the specialty or anything, please let me know. You can email me, you can email Dr. Dinesh, and we can go on from there. So we're located up north, northeast of the US. If you look over here, we're actually more close to Canada. If you ever plan to visit, you can come directly to Canada and then you can cross the river, and we're right there, right next to Buffalo, 45 minutes away from Buffalo. It's cold here for the most part, but it's a beautiful place to be at. We're part of University of Rochester and Strong Memorial Hospital. This is the hospital itself. This is our dental tower where we do all our patient care and education. We do not have an undergraduate program for DMD. So most of our programs are graduate level. We have residency programs. So it's a lot of action going on clinically in this building, and a lot of different kind of patients that you get to see throughout your training. Just a brief history, some major companies basically started from Rochester: Kodak, Bosch & Lomb, Xerox. UOR is the biggest employer right now. There's the Finger Lakes over here, and a lot of good places if you're into nature to basically hike and look around. George Eastman established the Rochester Dental Dispensary somewhere around 1917, and the mission at that time was to basically improve the health of children, go towards more of a education route, and also have research. In the 1920s, established a School of Medicine and Dentistry, and we had the first designated department of oral biology, and research was a main component of it. Between the 30s to the 40s, there were 5 more Eastman locations throughout the world that had started running, and it became pretty much an international chain where dental education and dental treatment was provided to patients. 1999, joined the University of Rochester. In 2008, we became the Eastman Institute for Oral Health. Now we're part of University of Rochester Medical Center itself. Dental specialties have evolved in the last few years. There's no question about it. Presently, it depends on what country you're in. Some specialties are recognized, some are not. In the US itself, there are 12 recognized specialties by the American Dental Association. Orofacial pain is one of them. It was approved a few months ago. And I think it's important to understand and recognize it because of various reasons. Number one, it's that gray area that's present between healthcare providers and dentists. You don't usually see a patient that has odontogenic pain coming to orofacial pain clinic. And sometimes you do have to think outside of the box to make sure that you know what you're trying to treat or what you're targeting at in terms of management. There's around 10 to 12 schools in the United States that have a CODA accredited program. If you do plan to pursue a career or education in this, it's important that you do go to a program that is CODA accredited. That is basically the Commission of Dental Accreditation. The structure for all the programs throughout the US is pretty much almost the same. There's either a 2-year residency program or a 2 or 3-year residency program with a master's if you're interested in that. There are clinical preceptorship programs. They can range from anywhere from 3 months to 1 year. This is usually more geared towards dentists who already have training or are far away in their career and they want to have just some more education or training. And then if you want to go the research route or the academic route, we do have master's and PhD programs also available. This is the format of our program at Eastman. We offer all these programs over here, and students decide on their strengths and weaknesses where they want to go. Research is a very big component. In your second year, a good 40% of your time is dedicated to research. There is both opportunities for clinical research and basic science research, depending on your interest that you develop within the first 6 months to a year. We tell our students to decide what area they would like to explore. We work extensively with different universities all around, pharmaceutical companies sometimes, but within our university itself, we work exclusively with neurosurgery, anesthesiology, physical therapy, and other departments, and we have a good collaboration going on. These are some pictures of our residents, our team, some good times. They've been lecturing, during their training. So coming back to the main topic of why pain. I think as dentists, majority of the patients that do present to us or come to a clinical setting will come for 2 reasons if you look at it. It's either aesthetics, function, or it's pain. And when we look at pain itself per se, I think that is one area that basically is a part of all specialties. Regardless of what you do, you're always going to have a patient that's going to come with pain. And, for the most part, where we are very good at basically diagnosing and treating the pain conditions that we see in a dental setting. patient will come, you'll do a root canal, you'll do an extraction, you'll do a filling, you'll do some sort of intervention, and the patient will walk out without pain. And I think that is the mindset that a patient has when he walks into a dentist clinic. The problem becomes for that little population, you know, depending on the data, 3 to 5%, that regardless of whatever kind of treatment you do, the pain never goes away. And that is where, you know, we sometimes need to make sure that we're looking at all the other aspects that can be causing pain at different regions. I always tell my students, we need to remember that the tooth is connected to a nervous system. And if there is a pathology somewhere in the nervous system, that definitely can manifest pain in the facial region also. So it goes both ways, and we need to be able to make sure that we recognize that, and we're able to basically have a differential based on what we see. So the International Association of Study of Pain is an academy basically that encompasses all different areas of pain specialists. You have nurses, physical therapists, neurologists, anesthesiologists, dentists. One of the biggest academy that is out there. And according to them, the definition of pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Now, when you look at the definition part of it, it doesn't do much, you know, justice. It's a very broad definition. Pain is way bigger than that. We know that, you know, everybody has a different experience. Everybody perceives a difference. Everybody reacts to a different. And everybody, you know, the management or the treatment that you provide to a patient is also the way a patient reacts is very different too. I think when we talk about chronic pain itself per se, we probably have the most options out there for chronic pain in terms of treatment. You look at it, acupuncture, hypnosis, chiropractors, physical therapists, surgery, biofeedback, cognitive behavior therapy, medications. Even with all these options out there, the clinical success rate is between 30 to 40%. And that's extremely poor. And one of the reasons is that the underlying mechanisms are extremely and poorly understood to why this happens. Why is it that somebody goes from an acute phase to a chronic phase? Why is it that somebody doesn't go? And that's the challenge. The other challenge is that many times when we don't know the underlying mechanism, we're basically treating a patient very blindly. I might think medications work best, and I might be inclined towards a few medications that I think work best in my hand, or I think, you know, over the years, my clinical experience says that it's the best thing. On the flip side, you might think something else might work for the patient. And, you know, I can't say I'm right or you're right. It's just that it depends on the healthcare provider, how and what they want to treat. Depending on the area of dentistry, like I said, we're responsible not only for the relief of pain, but in some cases we can cause pain too. If we look at it, dentistry is probably one of the areas where on a daily basis, millions of people get surgery. They get, you know, where we're playing with nerves all the time. So the prevalence of nerve damage and pain develops secondary to nerve damage, which is referred to as neuropathic pain, is extremely low in the dental world. We never hear that somebody went for an extraction or a root canal or a cleaning. You know, all these basic procedures that we do on an everyday basis causing this long-term pain in patients. And, you know, that basically makes the trigeminal system unique, because it makes you wonder that, is there a protective mechanism that the trigeminal system has as compared to the rest of the body? So there's a lot of ways to classify pain. I'm not going to go into details of that, but you can classify pain according to its location, its duration, its intensity, its frequency. But I think the most broadly accepted classification along all different areas of medicine is according to its duration. It's acute or chronic pain. And I think we do know the main difference between acute and chronic pain, but the hallmark is that to understand that if somebody has pain that does persist for more than 3 months, and it's pretty much the same pain in terms of its quality, frequency, intensity, at that time point, we can safely say that it's starting to develop into chronic pain, or it is chronic pain. The gray area is 3 to 6 months. After 6 months, we start considering it chronic pain for sure. When somebody comes with acute pain, a patient or anybody else, we need to understand that we're treating the acute pain. The management and the prognosis for acute pain is very successful and very good. We know the underlying mechanism or what the cause was. For the most part, is trauma or infection. We clean it, we take care of it, and the pain goes away and everything's back to normal. Chronic pain, on the other hand, is something that we cannot treat 100%. And I think it's very important as healthcare providers, especially as dentists, because our success rate to treat pain, especially acute, is so good, that we want to make sure that the expectations of a patient and our expectations as a healthcare provider are on the same level. We need to educate the patient and let him know that the treatment options are not the best. The success rate is around 30 to 40% reduction of pain. So what we can do is we can manage the chronic pain. And if these expectations are set from the get-go, I think it serves both the patient and the doctor in a good way. You develop trust and you know what is realistic and what can be basically accomplished. Acute pain usually is a symptom that there's something going on. It's basically giving the body a warning signal that you need to take action. Chronic pain itself is a disease, and there's a lot of different chronic pain conditions out there that basically we just treat or manage, but we can't come up with a definitive treatment option for it. This is the classification of orofacial pain that we use, and it's used throughout. I'm not going to go into details of all of this. I mean, I think each block over here is a separate lecture. But the important thing over here is to kind of understand and appreciate the fact that there's axis 1 and axis 2 over here. Axis 1 will basically talk about all the physical conditions a patient can have. Axis 2, on the other hand, are psychological conditions. And I think that's very important as dentists to recognize these. We're not trained as mental health providers, and I'm not saying that we need to start doing that, but I do think there are some very good validated questionnaires out there, very brief ones, that we can use to see or recognize if this patient does require any sort of mental health treatment at that time, or if we want to refer the patient. Especially when you're treating chronic pain, what happens is that, if you've had the pain for long enough, these conditions do play a role, and they're comorbid or they're concurrent with your chronic pain. And if a patient does have psychological issues going on with the physical condition, and you're treating only one, your success rate even goes down dramatically. So you want to focus on both, get the help of different, healthcare providers, and have more of a interdisciplinary approach when you treat these patients. So for the purpose of this presentation, what we've decided is that we're going to keep it simple in terms of musculoskeletal, neurovascular, and neuropathic. Musculoskeletal is when the origin is from a muscle. You could have myofascial pain. It's the second most painful reason for a visit to a dentist. Neurovascular could be, your vascular system is affected. It could be secondary to headaches. It could be due to tumors, whatever the reason is. And neuropathic. Neuropathic, for the most part, can be caused by central or peripheral nervous system lesions, but for the most part in dentistry, what we see is it's when there is nerve damage. And this nerve damage can be due to anything. It could be due to fractures, direct blow injuries, extractions, bunch of different reasons that can cause this nerve damage leading to neuropathic pain. One of the things that I want to share and talk about very briefly is the post-operative chronic pain. If we look over here, these are some very common medical procedures that are done: thoracotomy, limb amputation, bypass, mastectomy for patients who have cancer. And when we look at the numbers, we can see that the percentage incidence of chronic pain is anywhere from 30 to 50%, pretty high. But when you subcategorize that into the incidence of disabling pain, it goes down dramatically. So when we look at these numbers, globally or nationally or on a local level, you want to make sure that you do basically differentiate between the incidence of the pain versus the incidence of disabling pain. These numbers are still high, but that's a very important distinction that you want to make. Now, when we move to the trigeminal system, we look at some of the common anomalies or things that we see in a hospital setting: zygomatic fractures, orthognathic surgeries, extractions, endo. We can see that the report in the literature is about altered sensation, and the range is anywhere from 5 to 30, in some cases 5 to 70%. So that range is so broad that, it looks like everybody who's getting orthognathic surgery, the big chunk is going to get pain developed later on. But that's not true. when you look at the actual numbers of neuropathic or pain developed or disabling pain, those numbers are either not reported or extremely low. And that comes back to the same thing that, you know, the treatment options or the diagnostic recognition of these conditions is very poor. The training is very poor for us in many cases as dentists. You know, the third thing is that even though if you get to the diagnosis, the management is even more complex because we really don't know if there's a gold standard to treat these conditions. And that becomes very challenging in many cases. So we have our limitations, but I think it's important to understand that things like these do happen. I think dentists being one of the specialties that deals with all sort of nerve damage all day, not only need to be more educated, but need to be able to recognize the red flags when they see a patient that does have any sort of problem. So this is very basic stuff. You know, we have this cycle. There's tissue injury followed by inflammation and pain. Healing happens. Everything is good. We go back to normal, short process, referred to as physiological pain or good pain. That is the pain that is helping us. It's our friend. It protects us. In some cases, even after the inflammation goes away and healing happens, the pain doesn't go away. And at this point, there is no biological purpose of this pain. In fact, if it does stay for long on, it becomes a major problem for both the patient and the healthcare provider in terms of management. The patient is frustrated because he's going to different people and doesn't know why the pain is not going away. The healthcare provider is trying to figure out what the best treatment option for this patient will be. Will he respond or will she respond to something specific? And it becomes a challenge at times. So the normal process of pain, there's receptors usually on the periphery, nerve fibers, action potential, and it goes. But it all starts at the periphery. Skin level, we have different type of nociceptors or receptors that are stimulated by different type of stimuli. This stimuli that can activate a nociceptor or receptor is referred to as a nauseous stimuli, anything that has a threat to cause pain or damage. And for different kind of stimuli, there's different kind of receptors. So for heat, there's the TRPV1, V2, V3 receptors. For chemical, for mechanical, for cold. And a lot of research is basically focused on how to basically modify or block these receptors to reduce pain. In our side of the world, capsaicin is used a lot for osteoarthritic pain, and it works on villonoid receptors, which is one of the receptors that helps in burning. So there's different type of research done at this level to see if pain can be blocked at this level. Once the receptors are activated, this information goes to different nerve fibers. There's A beta fibers, A delta fibers, and C fibers. And it's important to understand that this, what the difference is. A beta fibers are large, thick fibers. They're myelinated. And what they do is they take the information of light touch. When we have a patient of trigeminal neuralgia or we're doing our examination, we take Q-tips, we lightly touch it on the skin. We're stimulating A beta fibers. This information travels very fast. Usually these fibers are not painful, are not pain transmitting fibers, but under some conditions, for example, if there's nerve damage, and there's phenotypical changes, these fibers can start transmitting pain information, which they're not designed to. A delta fibers are smaller than A beta. They are less myelinated, and they basically carry the information of intense mechanical and thermal stimulation. C fibers are the fibers which are small and unmyelinated. They're deep down, and these are very slow transmitting fibers, and they're usually responsible for that dull chronic background pain that somebody's experiencing. That sharp shooting pain secondary to pulpitis or that intense pain that a patient is experiencing is usually due to A delta fibers. Like I said, A beta fibers are not involved in pain, but in some conditions, they can start transmitting pain. Once this information goes from the periphery to your nerve fiber, it goes all the way up to your spinal cord. The reason why it's important to understand this is because if we look over here, A beta fibers, C fibers, and A delta fibers end up in the spinal cord at different levels. Now, these areas where they end up are known to as laminas. So you can see A delta fibers merge up or end up in lamina 1 and lamina 5, whereas C fibers end up in lamina 1, 2, and 5. The important thing here is that if there's a pathology, for example, lamina 1, it can basically affect A delta and C fibers at the same time. So if a patient comes to you and says, I have pain in my face on the right side and you do all your diagnostic testing, look for everything, and you can't find the source, you need to start thinking maybe this is a central process or something else is going on. So just to summarize what we talked about, the first thing is basically the activation at the peripheral level. This is referred to as transduction. That's the process when the external information of the world is transmitted into a language that the body can understand. And that language is action potential. For dentists, this is important. We use local anesthetics all the time. And once we use those, we stop that information basically going on to the next level, which is basically transmission. This information will go from the periphery to the spinal cord, usually the dorsal horn, cross over to the ventral horn, and then goes all the way up to the brain, to the somatosensory cortex. The important thing over here is that this information needs to go all the way up to the somatosensory cortex in order to be perceived as pain. If it does not go here, it's usually not perceived as pain. The beauty of the central nervous system is that once this information reaches the somatosensory cortex, the central nervous system has the ability to modify this pain signal, which means is that either it can enhance the pain signal or it can inhibit the pain signal depending on the situation. And I'll throw a very general analogy for that is, for example, if somebody's playing soccer or some sort of sport outside, during the moment, even if they're hurt, they might not feel the pain. And the reason why is because the central nervous system knows it's not a threat at this point, or it's not a significant threat at this point, and will keep on dampening those pain signals from going to the central nervous system and, you know, basically inhibiting your ability to play. So you keep on playing, you might go home and you'll be sore or it's going to hurt later on, but during the moment, your brain or your central nervous system has the ability to inhibit that pain signal. On the other side, the central nervous system also has the ability to facilitate or enhance a pain signal. And an example would be if you get cut, you get hurt, you know, any light touch, any signal, any, you know, contact you have in that area will be perceived more painful. Both ways, you know, you're going in different directions, but the idea is to protect the body from further damage. So that's how the nervous system works in brief. So we did talk about different fibers and what their role is, you know, and the reason why I mentioned that is because it's important to understand that, you know, not only do these fibers carry different information, but these fibers can help us understand different conditions in a clinical setting. So, for example, heat is, you know, transmitted via the C fibers. Remember, they were the non-myelinated thin fibers, small fibers, cold with the A delta fibers. Both of them are responsible for pain. Mechanical and electrical stimulation are by the largely myelinated thick fibers, which are our A beta fibers. The way we can use this in a clinical setting is, for example, in this case over here, we had a patient that came and, you know, there was some implant neuropathy going on, and you can see that the canal is violated. But the interesting thing is when you look at the electrical and thermal sensory testing results, you see that the threshold of pain has increased over here as compared to the ipsilateral side, both for the electrical and the thermal testing. So this can give us a good idea of what stage the nerve damage is in. For example, if there's neuritis, which means if there's inflammation or an inflammatory condition of the nervous system going on, you know, your threshold is going to be different versus if there's permanent nerve damage. There's malignancies, sinusitis, orthodontic treatment, TMJ disorders. All these conditions show that your pain threshold levels will change in certain situations. Sinusitis is the most common cause, you know, that one of the most common ones that's seen. And I'm not going to go into the details of that, but what I want to show is that if you have a patient of acute sinusitis and you do electric detection thresholds, you can see that the threshold has decreased for this patient. He's responding to a stimuli somewhere around the 20s, you can see, compared to controls. Now, when you look at the same group, but with chronic sinusitis, you can see that the threshold has increased. So the same condition, depending on if it's acute or chronic, the thresholds decrease or change dramatically, giving you underlying information. So just to summarize that, If there's an inflammatory condition going on, the myelinated fibers detection thresholds are reduced. That means you need less of a stimulus to provoke a response. On the flip side, if there is permanent nerve damage and it's chronic in nature, your threshold will increase dramatically and it will be irreversible. A lot of people use these kind of techniques in an oral surgery setting where they have 1-5 filaments. Some people use pinprick, and some people use all different kind of sensory testing modalities. There are dedicated machines for that, which are expensive. I think you can use very simple tools that we all have in clinical settings, Q-tips, the soft part to brush, stimulate A beta fibers, the back part of it, which is pinprick. These are testings that we can do very fast and very efficiently to see if there's a pattern of nerve regeneration or sensory alterations coming back or not in these patients. So I'll stop over here, and I think we'll go through the different cases that we have. But does anybody have any questions? Before we get into the next phase, you can message them to Dinesh. I'll be happy to entertain all the questions. If you guys want to go and have them in the end, I'm okay either ways. Dr. George will take over, and he will be going over the first case now.
Dr. Robby, you're mute. Yeah.
Okay. Hello, guys. Sorry about that. So thank you, Dr. Junad. That was a big crash course on how orofacial pain is and what type of patients that we dealing with. One thing I want to talk about is what do we do in orofacial pain? How do we treat? The average patient that comes in, they would have seen about close to 6 to 7 dentists before they finally end up with us. The question is, okay, what do we do? So, of course, any case you do a brief history, a physical exam, and diagnostic imaging. But in our case, we spend about close to an hour or maybe even more than that with the patient for our initial exam. That is like, you have to talk to them a lot. Now, one basic thing is you just want to get a good relationship with these patients, because most of these patients, they would have gone to different doctors and nobody would have believed that what they're saying is true. So for us, when we go into detail about the patient history, so what we do is, like, we ask, as usual, the same things: chief complaint, history of personal illness, past medical, past dental, psychological. The two different things we added over here is psychosocial history and sleep history, which is very common that you see. Hold on one sec, guys. So regarding this case number 1, hold on one sec. Okay, case number 1. This is a case that we saw. Actually, Dr. Junad saw this case about 4 or 5 years back, maybe more than that. It was a 40-year-old male who had come with pain on the right side of the face for past 1 year. But when we said, the questions we ask when the patient comes into orofacial pain is, this is the format we go through: onset, location, quality, intensity, frequency, duration, associating factors, aggravating factors, and elevating factors. We have to go through all these questions. By the time you take a brief history, like if you go through all these questions, you might get a basic idea if it's a neurovascular, neuromuscular, or maybe it's myofascial pain. How do you come to that? For example, onset. If the patient says, in this case, the patient said that the pain, I don't know, it just happened maybe 1 year back, but the only thing he said extra was, like, I had a fall maybe 5 months back, and the pain got worse. Okay. Then we asked where the location is. He said the right anterior segment of the maxilla radiating to the tip of the nose. And another important question we ask is quality of the pain. How do you ask quality of the pain? It's like, in this case, the patient said it was sharp pain, but what are the qualities of pain they ask for? You ask for, is it a dull aching pain, or a throbbing pain, or a burning pain? These are all the questions we ask. So each question have a different diagnosis. For example, if it's a throbbing pain, you know that maybe you can go under, say, okay, neurovascular, like a headache type of pain. If it's like a dull aching, it might be myofascial pain, myogenic pain. And intensity. So you see some of those red flags I put in across. So those are things that we look for in orofacial pain. When the patient says something, okay, we have to understand that, okay, something is wrong with these patients. Intensity is, intensity is like, it's subjective. Like the patient will say, doc, I had pain before, but it was not that much. And now it's getting worse. So what we do is we usually have them on a VAS scale. VAS is visual analog scale, which states that, okay, the patient will say, okay, 1 being the best, or 10 being the worst. What is your pain when you had like 1 year back? He said maybe about 4 or 5, which is like a moderate pain. And when the patient says if it's like a 7 or 10, we think that, okay, maybe it is a severe pain that he's coming through. For example, in this case, the patient said that when he had the pain back in maybe a year back, it was 4 or 5. And now he's saying that it's more close to 7 or 10. And another question you want to ask is if your frequency is periodic, like episodic or intermittent, the frequencies. Why do we ask that? If a patient, some patients will say that, oh, doc, the pain is always there. It doesn't even go away when only time it goes away is when I do something. So that's another thing where you can diagnose that. And duration is another thing that you look for. Some cases, it says, doc, the pain lasts for seconds, or then it says, in this, maybe lasts for minutes. In this case, the patient said that in the beginning, the pain was lasting only for seconds, and after a while, it progressed. The patient said the patient's stop pain lasted for 2 to 3 minutes. In this case, the another interesting story was the patient said he had a dull, aching pain in the background all the time, but it wasn't the pain that he was here for. It was a sharp pain that he wanted to look for, and it was. Then another thing you look for is associating factors. Associating factors is, okay, what associating factors do you have? Okay, the patient, does he have a redness, or does he have tearing? Does he have any other functions, other features that's affecting on the side? And in this patient, he had none. He is perfectly normal. And another question we ask is aggravating factors. Aggravating factors is, when you do something, do you feel the pain is activated? And in this patient, he said he's fine, and there was no issues with it. And elevating factors is what takes the pain go away. In this case, the patient said that he used to take over-the-counter medications, which maybe slightly helped him later on, but right now he said that it doesn't even help him at all. And the medical history, he was a healthy 40-year-old man with no significant medical findings. Only thing he said was he had trauma where he fell on the face and hit on the right side about 5 months back, and after that the pain started increasing even more. So another thing he had said was the past dental, he had right and left central incisors that were extracted due to pain. So that was interesting that we will watch it. Another question that Dr. Junad had told you about, maybe then 2 extra steps we do with is psychosocial history and sleep history. Psychosocial history is mainly because most of maybe about 40% or 50% of chronic pain patients might be diagnosed with depressions. We have seen that, and there's research published on that. Another thing we always ask is for sleep history. Why do we ask for sleep history? The thing is, everybody knows that if you don't have enough sleep or REM, then the pain, whatever you feel, will be over, like it'll express even more. So another question, the reason the questions we ask is, well, do you fall asleep very easily? Do you take any medications? Do you drink alcohol? Or do you gasp for air at night? Or are you feeling exhausted like throughout the day? And the patient said he was fine, he had no issues with it. Another question, and then we go to physical exam. Physical exam, general exam for head, face, and neck. Intraoral, extraoral, you guys know. In extraoral, we do specific steps like cranial limb screening, musculoskeletal screening, TMJ evaluation, and cervicogenic examination. We'll talk a little bit about that. And of course, we talk always about the sleep history, and always we ask them the headache history. The first thing they'll ask is, when you ask them headache history, what do you ask headache history? Why is the dentist asking me a headache history? So always say that, it's just to make sure that there is no other comorbid issues that are with other, like with any issues they have. For example, right now for the physical exam, we do a face and neck exam. In this case, what we do is like just observation and manipulation. Like, we look for any tumors or swellings or redness or any other issues that they have. in the TMJ eval, what you do is just like you guys do. I don't know if you guys do active and passive motion, asking to open the mouth, close, any crepitus, and we check the range of motion, any deviation, deflection. In this case, the patient was perfectly fine. Now, musculoskeletal muscle examinations, we usually do, what do we do that for is find if you find trigger points in the patient. In this case, the patient had, when we palpate the masseter on the right side, he had slight discomfort, but it wasn't the pain that he's in for, like the sharp pain that he is for. So another thing we saw, like intraorally, like I said, central national incisors were like extracted about 3 months back. Another thing we did notice that was, we were talking about Dr. Junad was talking about A beta fibers, loss of sensation on the V2 division of the maxillary nerve. So it was right here on the right side when we do, like, I'll show you what we do for exams. If, for example, this is like this, when we do a cotton swab, we would do it on both sides, right and left, and see the patient will say, do you feel the same on both sides? Usually if the patient does have some loss of sensation, they'll say, oh, doc, I feel the cotton more on the right, not much on the left. Another thing was, we do a pinprick, we use like an explorer or dry needle, and we just prick them on both sides and say, do you feel the same on either side? And the patient, in this case, the patient said, no, it was not the same case. So that's what I have. So I might have some opinion. I don't know if I gave you a good history. So this patient, I'm going to go through it again. A patient is a 40-year-old male, completely healthy, 40-year-old male, completely healthy, no, not any medications. Started with pain 1 year back. He had pain. It was a sharp pain, but it was maybe for seconds. Then after that, the pain increased after following trauma, which was about 5 months back. The patient had got his tooth extracted, number 7, central and lateral incisor. Still after that, the pain still didn't go away. The pain worsened after that. And what else? So what do you think? If it comes to you, maybe is there a way that, I just want to see what you guys think. So in this case, we were actually supposed to do a poll, but it was too late, we didn't do it. In this case, this would be a differential diagnosis, which we think about. So, for example, in this case, what we do is, after that, we do a diagnostic test. What do we do diagnostic test? This is one of the things that we do a lot over here. You want to know if the pain is central or peripheral. So how do you do that? Diagnostic is like topical anesthesia. So what we do is to take a cotton tip, we apply topical anesthesia on the place that the patient complains of pain, and we see if the pain is still there or it goes away. If the pain goes away, then you know that for sure, okay, it is a peripheral pain. And if it doesn't go away, then you might think that, okay, maybe there's something more to it. So what we do is, after that, is we do a block. So most of the time we use Lido, a short-acting Lido without epi. And we do that into the place where we do, where he points it out, just to see that if the pain goes away with the block. And when, in this case, the patient, the pain did not go away at all. He said that pain is still there, and it's like he said, it is still there, but it's not going away. So I said, okay, for sure we knew that it was not something that was more peripheral, but they had a central to it. So in this, after we saw this, after we did this test, we ordered an MRI brain scan. So this is what it came out with. This patient had a big mass on the cerebropontine angle on the right side. It was encasing the right cranial nerve and the basilar artery. The reason why I'm saying this is, you might see some of these patients coming in. This patient had extractions done. The patient had a lot of treatment done. For example, for us, we saw that the extraction might have been unnecessary in this case. So let me see, another thing is, so like I said, it was a tumor diagnosis, was cerebropontine tumor. So let me, and I was talking about the red flags, right? These are the red flags we look for when we ask the patient. So dental pain gets worse over time. What is that? What does that mean? It means that if a pain is there for such a long, maybe after 3 or 4 months, and if you had taken the tooth, in this case, what I'm talking about, if the patient had taken they did take the tooth out, but the pain was still present in the patient. Another thing is another red flag is age of the patient. For in this case, why we ordered an MRI is because a 40-year-old does not come up with a trigeminal neuralgia. I mean, like you don't see a 40-year-old with trigeminal neuralgia. And in the trigeminal neuralgia, you will always have a trigger point or trigger zone where you can activate the patient. And new progressive headaches is one of the things we look for. If the patient say that the headache is there, but right now it's even getting worse than what it was before. Another thing is, doc, when I start running, I get my headaches. Another thing we'll ask for is, does it wake you up at night? There are two questions we ask. Do you wake up with a headache or a headache wakes you up, which is two different things. And it gives you maybe a little bit idea, maybe it was centralized. Another question we ask is, a headache, does it come with any symptoms of any nausea or vomiting, and headache followed by any neurologic symptoms? So this is what was my first case I presented. So you guys, hold on. If you have any questions, let me just, Dinesh.
Dr. George, there are a few questions there. I think we can take the questions at the end because we are already out of time. So I think we'll take the questions at the end.
Oh, okay. Dr. Shilpa.
Yeah, I'm doing it. Can you all see my screen?
No, doc, it's not visible.
Now, yes.
Yeah, doctor, go ahead, please.
Yeah. First of all, thank you, Dr. Dinesh, for organizing this, and thank you to George for, making this happen. And thank you, Dr. Khan, for having me here. This was a very good presentation here. I think Dr. Khan and Dr. George already had made the background here. I was reading through the questions, and I think when we all will go through some case scenarios. I think most of the questions will be taken care by the end of the session, and pretty much it's a vast subject, and I don't think so we can take care of almost everything, but there were a few of them which I think we are covering in our case scenarios. So here I present my case number 2. This is a 43-year female who presents to Orofacial Pain Clinic with chief complaint of mandibular anterior teeth. Having said that, when the patient come to us, we can always, like, the patient is saying pain in the teeth. We are oral health care providers. We are not just dentists. When we do our exam, we have to be very thorough and very careful how we extract information from patient. As Dr. Khan or Dr. George already mentioned, that history taking is so important, and how we extract the information is another important thing. So in this case, when the patient comes, she just says, 6 months back, I started having pain, and I feel that, it's more like a sensitivity. Definitely, now we will start looking as a dentist, but if we follow the exact way of taking history, we will never get distracted. So when we asked more further, the patient said that when I was one fine day yawning, I had a stretching sensation, and my jaw started to hurt. And I think after that, I started to having, sensitivity in my lower mandibular anterior teeth. 6 months back, definitely the pain was pain she explains as dull, achy pain. But she also says that whenever I'm trying to open my mouth, it's become a little sharper and a little sweeter. So we always have to ask, what is the intensity? She rated the pain around 2 at the scale of 10 on the VAS. But when the sharp pain comes, she says that it's like, and it hurts a lot. When we asked, like, what is it which is helping you? She said, this is continuous pain, and nothing helps me, nothing aggravates me. I cannot relate anything which can aggravate the pain or increase the pain, or there is nothing which can relieve my pain. When we asked for any autonomic features, what are autonomic features? Anything related to flushing skin, redness around the area, or tearing eyes. Very important to know, as Dr. George said, that we have to really rule out every possible way while doing the history taking, if there was sympathetic pain maintained with it. So she said nothing, there's no associated features to it. Now, there was nothing as far as her psychosocial history was. She said that I'm pretty happy person, but just I'm a little stressed out because of all this, whatever happening. When medical history, she said nothing, really nothing, but then she suddenly said, oh yeah, I have gastritis. Okay. She said, well, probably 8-9 months back, I had Bell's palsy on my right side. I was treated with prednisone and I was okay. And after 6 months, just when I was okay, so suddenly I had this occurrence of pain in my anterior teeth. When we further inquired about her previous interventions and everything, which is part of her exam as well, we would like to know where she has been, because we don't want to end up giving something similar, right? And we are going to lose the patient back again. So when we asked, she said, I went to one fine dentist, and she thinking that this is just a sensitivity. They were a lot of desensitizing toothpaste were ordered, prescribed over-the-counter medications, nothing helped. Then she further consulted, ended up getting root canals in the mandibular anterior teeth. A lot of antibiotics and multiple time endodontic treatments were done for mandibular anterior teeth. Ended up getting extractions from canine to canine with no significant results in the pain or the sensitivity what she was having. In fact, it was the same. Then she was diagnosed thinking that she has trigeminal neuralgia. She was treated with carbamazepine and pregabalin. Carbamazepine was 300 milligram and pregabalin was 75 milligram once daily, along with vitamin B12 for about 3 weeks, with no results at all. She said the thing remained same. Well, then she further consulted, and she was stated that, you know, the dentist stated, let's start with the partial dentures because you have missing anterior teeth. The dentist started with the impressions and everything. When she was getting through the work done for her partials, suddenly her pain started to get worse. There, when she was referred to oral surgeon for further evaluation. The oral surgeon looked at and he said, let's go for a occlusal guard. And she was given a occlusal guard. After that, she arrived to our clinic. Before she arrived, there were several testing already done. Panoramic, talk about anything, tomography, CT brain, MRI, everything was done. Even thyroid profile was done. Nothing came positive in all those examinations or diagnostics, except that CT scan just suggested that there is a nasal septum deviation, which was probably not very significant to what she was currently stating of the pain or the chief complaint. Then we usually perform a complete, thorough, comprehensive extraoral and intraoral exam. In extraoral, we will include the cranial nerves, we'll do the Tmj exams, muscle palpations, intraoral exams. In cranial nerves, there was nothing much specific other than the right side facial muscles, which are mildly, weak. Well, probably we can, as we know that the patient had a history of Bell's palsy, maybe that is related to that. The Tmj examination usually includes the range of motion of the jaw, how the gait of the jaw, how it moves, and the muscle palpation of the mastocytory and adjacent muscles. When the muscle palpation was done, the right superficial masseter muscle, right SEM, sternocleidomastoid muscle, and anterior digastric muscles were tender to palpation, and there were trigger points. The right anterior digastric trigger point, when palpated, was able to reproduce the similar familiar pain in what the patient actually was having. When did the intraoral exam? Obviously, there was partial edentulous area in the mandibular arch, which was canine to canine, which is understandable, and now we know why it happened. There was also noticed that there was a bony spicule in the extraction site on the right side of the canine. Well, when we palpated it, it was little tender, but not really able to reproduce the pain what she was having. The familiar pain is very important to ask again and again when we are palpating or when we are looking at the teeth. Even when we are percussing the teeth, we always ask, is this what you get? Is this what you familiarize? Is this something new or something what you think about? So that gives a lot of idea to us. Now, the range of motion, usually when we do, we look at how much the patient can comfortably open. We have to we have to see if the patient is able to open without pain, without joint sounds, or how much limited or not. So the normal opening is somewhere from 35 to 50 mm. Less than 35 usually is considered limited. We also look at the lateral excursions like left, right, how the patient can move the jaw, and the protrusive movements as well. Everything should be in 4:1 ratio. 4 is the normal range of opening and 1 is the lateral excursions and the protrusive movements. Now, gait of the mandible is important to see how the patient is opening. We start to ask the patient to slowly open, and we notice if the patient is deflecting or deviating back to the straight line. These all are really, well, one, we can say that they are significant. Yes, they are significant because they give us the idea how the joint looks like, how the intracapsular and extracapsular components of the joint are, and gives us the idea what we have to do and how we can go further. So we also did the sleep history, which is part of our routine exam. It gives us how the sleep of the patient is, how the patient, if there is any sleep apnea, if we really need to, refer the patient for that. In this case, the patient said that there's nothing which, gives us any trouble, gives me a problem in sleeping. She actually said, I can pretty much sleep very well. The only problem is that I have problem initiating my sleep and then maintaining the sleep later. She also stated when we were really examining, she said that I'm a mouth breather. The rest was really non-significant. Mallampati and everything was normal. There was nothing very significant to give us the idea, okay, this can be a sleep apnea case. We also do the headache history. There can be, in orofacial pain, we usually evaluate the patient for headache history. There was nothing she mentioned. She never had any headache histories. She never complained of any headaches. While thinking on this grounds, we could have all these things. Definitely, we as dentists are biased to think that maybe it's a dental pain. Or maybe if we are very aggressive, or if we have gone through some literature or literature or something like that, we would definitely say, okay, probably this is neurological or neurovascular. The last thing we would definitely think about the temporomandibulars or myofascial pain. Before even we go for differentials, we have to think what would be our next step. We have done our complete history. We have done our evaluation. We have extracted as much best information as we can from the patient as we wanted. Now, what should we do next? Should we really go for an MRI? She already had one. Should we really go for a CBCT because she never had one? Because she had a CT, if we know from our history? Or should we go for a blood test, serological testing, because I think she only had the thyroid profile? We could order all of these. I mean, does it make sense? Are we really helping the patient at this time? Is the patient going to come back to us if we do all this? Are we retaking the patient's faith on us? That is very important how we go forward. So now, as a next step of treatment, we should actually go for topical anesthetic, which makes sense also. That let's see, as a dentist, let's see if we apply the topical anesthetic in the area where the extractions were done, if the pain is going to go away. So we started with the topical, which is going to give us the peripheral idea, and we then go to the next step, which is infiltration, and we'll see what happens. We did that, and the patient said, no, there's no relief in the pain. While panoramic usually is not a very good way of good diagnostic for us, but very easily available in dental clinics and can give us some pretty good idea about if there is some specific pathologies in that area. We never took one pan because we already had one from before, and when we looked at it, there was no significant findings which we could think of. So the next step now would be very good one would be to go for a vapor-coolant topical spray. We use the ethyl chloride here. We took the topical spray, we sprayed it along the belly of the anterior digastric. Now, if you remember, when we were doing the muscle palpation, there were 3 muscles we had, the SCMs, the superficial masseter, and the anterior digastric. Only the anterior digastric was able to give us the referral or familiar pain to what the patient was actually complaining of. So we took the ethyl chloride vapor-coolant topical spray, we sprayed it on the belly of the digastric going towards the pain of the patient. We applied it, and the patient said, oh, the pain is gone. That is what I was having from past 6 months. This was not going away. So what does that mean? that means this is the source of pain. So in usually in our clinics, in our orofacial pain clinics, we also do our diagnostic testing, which is called the diagnostic trigger point injections in our clinic. But in this case, this was a digastric belly, and we wanted to get it done under the ultrasound guided injection technique, just because there could be some other places, you know, we want to know where the injection is going and all that. We don't want to have any other side effects or contraindications in this patient. So we referred the patient to the physician, got the trigger point done under the ultrasound guided technique. The patient was followed up later on, thinking now when we know with all these that this is a myofascial pain, trigger point injection was given. We also gave patient the palliative instructions, which would include the exercises and you know, self-care instructions along with biofeedback and all that. And the patient was really followed up in 6 months, and the patient was completely relieved with the pain. There was no pain at all, and she was happy ever after. So when we have such patients, it's important that what are some non-odontogenic areas which can cause us the dental-like pain. So sinusitis, as we all know, can be one of the reasons which can refer the pain into the dental region. We have to really ask questions accordingly. Definitely ENT pathologies. Temporomandible disorders are very common to cause the pain in the dental region, and are more prevalent when we see usually in our orofacial pain clinic. Also, the myofascial pain is also very prevalent and very common. And neurovascular, neuropathic are also few of them. And I think one of the Dr. George's case, you would correlate with that. So there are a few muscles specifically which give the reference to the, this is called zone of reference, to the area in the teeth. The myofascial trigger point for the masseter muscle is very, very particular in the teeth. Once you press the trigger point, the patient will start to say, oh, this is my pain, and I can familiarize the pain. And masseter, very common, just because this is the most used muscle in our jaw. Any para-functional habits, chewing gums, clenching, these are the few things which are always, this is the only muscle used in these para-functional habits. Upper trap is another one which has a pattern towards orofacial pain region and into the dental area, and we can definitely confuse it with the dental pain. The sternocleidoid muscle is another one which can give us the pain reference to the headaches and to the dental area in front, pre-auricular, post-auricular, headaches around the eye, behind the eye, exactly at the angle of the mandible. These are the few areas which are the specific zone of references for sternocleidoid muscle. Very, very common in orofacial pain patients. Temporalis muscle is another common muscle which can give a referral pattern to the teeth. Anterior temporalis muscle will give the reference to the anterior teeth. The middle will give to the middle bicuspids, and the posterior will give to the posterior teeth. Very common, very typical way of giving the zone of reference. So anterior digastric in this was a very particular muscle. We use this case just because little uncommon compared to what we get for masseters and temporalis. But digastric, this digastric muscle is very important in our jaw function. This helps in depressing and retruding the jaw. And it is a type 2 muscle. That means this is an active, fast-acting muscle. So that means in our jaw, this is definitely helping us in the parafunctional habits. Plus, when we took the history of this patient, the patient did mention us that mouth breathing was her problem. There, exactly. So now every detail of a patient is so important to know that this patient had the parafunctional habit of mouth breathing. And these are the few reasons where we can develop some trigger points or some myofascial pain related to the muscles which are working on these jaw muscles. So anterior digastric was the one which was working in her case, and she developed the trigger point, myofascial pain. So trigger points and terror points, they are two different things, but trigger point is actually a hypersensitive nodule in the taut band muscle. And when we press that, it can give us a pain into different zone, which is called a zone of reference and not exactly in the muscle area. Now, when we, if we refer back to our previous slides, we had masseter, temporalis, all of those muscles had a zone of reference into different areas, not exactly in the pain. The trigger points can be active, can be passive. Actives are usually very tender, and whenever you press, they will have the pain. But the passive ones are the ones which you, if try to palpate them, they will reproduce the pain, which is familiar. And the pathophysiology of trigger points usually is stated that when the muscle is worked up a little extra, the neurotransmitters from the motor and neurons will release the acetylcholine, which fails to go back to the motor and neuron, and then that is accumulated to form a nodule, and that is very painful usually. When we are doing trigger points, very, very important. Any injection, I think, when we do, or any intervention when we do, we have to know what are the contraindications and what are the complications. In trigger points, overall, we should know that the patient was on any anticoagulants, blood thinners. If there was any swelling in that area, please, please, please do not go ahead and do the trigger point. We would like to know if there was allergies. If there was acute muscle trauma, we should not give the trigger point there. Plus, we have to take the faith of the patient before we start the trigger point. The patient can be really nervous and can become hyperactive when we are giving the trigger points. Complications, they're not much complications. They are very simple, but definitely in trapezius trigger points, we could go into pneumothorax. We could break the needle. Well, that can be one, but definitely when we are doing the trigger points, hematoma formation can happen. So that's why when we are doing the trigger points, we have to be careful. We have the cold application ready, and when we start the trigger point, we do the vapor coolant spray before, and then identify the trigger point, palpate it, get the jump sign of it, and if the jump sign is there, that is where we have the right position of the needle, and we slowly inject the carbocaine injection, which is we do not want to inject the epinephrine in this, because epinephrine is a vasoconstrictor, and we do not want to close the blood supply for that muscle. Already there is a trigger point because of the loss of energy, ATP loss. We want to give more blood supply to that. So in this case, or in trigger points, we only give carbocaine, which is good for muscles, and we do not want to give epinephrine because that's a vasoconstrictor. So here we go. In this case, we identified that there was a trigger point in the anterior digastric. We identified that with the help of the vapor coolant spray, and the patient was able to familiarize that the pain is already gone. We started with the trigger point injection. We gave some home care instructions. Gave some ibuprofen, and in this case, since the patient mentioned, if you guys could recall, that the patient stated that she had some stress, we did refer the patient to the psychological counseling, and we were able to the counselor was able to diagnose depression as a secondary diagnosis. When we are doing an exam, there was actually a question in the panel as well. And when we do exams, we have some questionnaires which we are able to help the patient to identify if they have psychological stresses or any other such kind. So if we go to DCDMD, because we follow diagnostic criteria of temporomandibular disorders, we'll have GAD7, PSQ1. These are the few questionnaires which are very simple and very small questions and easy for the patient to fill, and they help us to identify if the patient, how is the patient's quality of life with the pain, if the patient is having chronic pain. And then physiotherapy is very important when we are having some myofascial and trigger points in that. Here is important that when we do the percussion of the tooth, we are always doing that. If the patient is positive, definitely that's a tooth pain. But if there was nothing, that means we have to start thinking that this is something beyond tooth now. Start looking into the x-rays. If there was no caries, think about non-odontogenic pattern. Go beyond the tooth. We have to always think out of the box and see that if this is not happening, then where it is coming from, where's the pain coming from. cold and stretch. If there was no change in the pain, that means the pain is definitely in some other place. When we did the anesthetic application, the pain was not changed. We have to go beyond now. What is the next step? Where is the pain coming from? If the pain is not changed, where is the pain coming from? Same way we did in this case also. We have this mesenteric nerve block. I think there was one question in the panels also. This is one of the way we can block the nerve. This is the mandibular branch of the trigeminal nerve splits when it comes from foramen ovale. It splits into temporal part and also to the mesenteric nerve, which supplies the masseter muscle. We could do this as well if we know that the source of pain is coming from the masseter muscle, and we can block the whole masseter and the patient will be happy ever after. But then there is another way of doing a twin block, which is we can block both the masseter and the temporalis muscle. So in this twin block, what we do is we will inject the lidocaine without epinephrine into the infratemporal fossa, where we have the temporal nerve and the mesenteric nerve. So what we will do is we will identify the zygomatic process and the zygomatic bone where there will be a depression in the infratemporal space. There we'll take the needle, it is about 30 gauge, and we'll wipe the area, clean the area, and then insert the needle over there. The depth along what we can go is somewhere around 1 to 1.5 inches. And we will inject the anesthetic very slowly and steadily. We have to be very careful that in this area, if we are trying, we have to look at our patient's eye, that if the patient is blinking properly, because we could inject or over excess let the anesthetic go into that area also, and the patient, but this block of the eye will be transient. The patient, as soon as the anesthetic effect is gone, the patient will be normal. So we have to make it sure that we tell the patient all these side effects before we start injecting in that area. So here is that we take the needle, go along that area and inject it very slowly into the zygomatic process. And the patient, we are here blocking both the nerves, the temporal portion of the V3 and the mesenteric portion of the V3. So in this way, we are able to release pain or relieve pain of masseter and the temporalis both. This can be also useful in patients who have dislocated jaw. The pain is excruciating in the temporalis muscle and the masseter muscle. The patient will be blocked, and then patient can go back to place his jaw back again. So this is a better way of dealing. The twin block is better than mesenteric, but again, it depends which nerve we are using. Are we using the mesenteric nerve? Are we doing both the temporalis or the mesenteric nerve? So again, it depends where exactly the pain is, how we identify. That's again, going back to how we take the history. Now, I just want to mention a real quick fibromyalgia. This is again, one of the most prevalent musculoskeletal complaint what we get in United States. I'm not sure about India though, but we do get pretty good amount of patients with fibromyalgia, mostly more common in females. Well, it can be in any age, but yes, and gender, but yes, it is most common in females. What is fibromyalgia? Fibromyalgia is a generalized body pain, chronic body pain, widespread in all the muscles, all the musculoskeletal muscles, the big muscles. The patient will always say that I'm tired. I have early morning stiffnesses. I cannot focus in my work. I lose my focus when I'm in work. So these are the few things. It's a debilitating condition. Patient do get disability based on fibromyalgia. Now, how we differentiate between fibromyalgia and myofascial pain. In myofascial, there's going to be tender points. There are multiple tender points. As per the guidelines, there has to be more than 11 tender points bilaterally out of 18 tender points to be eligible to be diagnosed as fibromyalgia. Definitely, it is known and there is evidence that in fibromyalgia patients, there will be sleep disturbances as well. And there's a lot of comorbidities. It is important for us as the orofacial pain specialist or as a dentist that this is a central sensitized central nervous system problem, and it is related to comorbidities are related to autoimmune disorders, and especially in the temporomandibular disorder patient as well. We do get a lot of patients who will have fibromyalgia and they will come with a complaint of myofascial pain region also. So I actually told everything here, and myofascial pain will have trigger points, and they usually can give a zone of reference and can familiarize the pain. But in fibromyalgia, there will be tender points, and definitely if you have to be eligible to be diagnosed as fibromyalgia, to have at least more than 11 tender points. When we give the trigger point in fibromyalgia patients, there will not be, there will be no relief of pain just because it's more of a central mechanism than the peripheral mechanism compared to which is what we get in myofascial pain patients. I think that's about it. I hand it over to Dr. George now.
Thank you, Shilpa. I guess you guys can hear me.
Yeah, go ahead.
So I was just one question that came in. Maybe I didn't explain really good. So there was a question. It said, why is the difference between you wake up with pain or pain waking you up? There's a lot of different series. Like for example, if you're waking up with pain, it's like maybe it could be due to a functional habit, like you're bruxing, you're clenching, or something like that. And pain wakes you up is totally different. Like, oh, you wake up and there's severe pain in your head. It's not the regular time that you wake, like usually 8 o'clock in the morning. I'm not talking about, or 6 o'clock or something like that. Maybe it's like 2 o'clock at night. And the pain wakes you up. So there's the two different issues in that one. Maybe I didn't explain it too good. Another question was like, another question I kind of found interesting is why is in pain different? Why if a patient is grinding, why the patient have headaches? There's two concepts in that. Dr. Junad already explained to you. The two concepts is there's one's convergence and there's another one called non-convergence. Non-convergence is when the same nerve is supplying to two different places. Like for example, glossopharyngeal nerve, it supplies your throat and your middle ear. So do you feel like, if maybe a patient will complain of a pain, oh, my ears are aching. But you know what? If it's neuralgia, glossopharyngeal neuralgia, you have pain in your throat. So another thing, another way to explain it is a non-convergence is when it's mainly a trigeminal nerve and brainstem complex, which we have 5, 7, 9, 10, and C1 to C3. When all these nerves, they have a spot which is called trigeminal brainstem complex, where any of these areas, the pain refers over there, it might be precise somewhere else. For example, cervicogenic headache, right? Even though cervicogenics, C1 to C3 is a peripheral nerve. When it goes in, it complains, when patient says that, oh, doc, I have a headache, but maybe the headache is not because of something else inside, maybe it was a different area of the pain. So I just want to explain that. Hope I answered some of that. So this third case I'm talking about, it's pretty fast. I'm not going to take too much of a time. This is a patient that was referred to us from ENT doctor. We have a good relationship with all the doctors. I mean, like neuro, ENT, headaches. So we usually get, we refer them or they refer to us, which we have a good relationship. So which was good. This doctor called ENT doctor said, they said, I'm sending you a patient. We are sending a patient. This patient have uncontrolled jaw movements, and she's going like on the right side. She opens her mouth and she sometimes protrudes her tongue out. And another reason she said that she had pain mostly on the right and the left ear, preauricular area. So the complaint was jaw pain and uncontrolled jaw movements. And the onset, she said that when the pain started is usually when she has persisting twitching of the lips and repetitive jaw movements where she moves her jaw to the right, she has an open jaw like that. And location mainly preauricular bilateral. And when she said that what type of pain did she have, she has a dull aching. So Dr. Shilpa, what I told you, like usually dull aching, we always think about it if it's like a myofascial pain or myofascial in origin, unless if it's neuropathic pain, like a burning pain, a dull aching, after a long time, it will be a, what do you call it? But dull aching pain, neuropathic pain would be mostly during a long point. So let me stop at that. Another thing is intensity of this patient. What said she said that it wasn't that much more. The PVS scale was around 4. The frequency is it's continuous, means continuous, it comes and goes, but it's there for a long time. And duration, she said it comes, it's there for all day, but she finds that aggravating factors is when she functions, like when she opens her mouth or during stress. And elevating factors is toothpick, which we didn't find that out. I'll talk about that later. So medical exam, she's 77, so she had only, other than hypertension, she was pretty good. And cranial, like I said, everything looked normal. The only thing is when we were examining her, she had one of those twitches. Twitches means she was moving her jaw all the side on one side. So what she did was she took a toothpick and put it in her mouth, and the movement stopped. So what we thought maybe she is using is as a neurosensory stent to stop the movement. And other than the hypoglossal nerve where she was uncontrolled movement, other than that, everything else looks good. The musculoskeletal and the palpation of the masseter produced maybe a little bit of the pain, but it was we could reproduce the pain, I can say. And TMJ, the lateral pole bilateral, she had tenderness. Other than that, everything else looks good. All of these things, when we did, we could not provoke the movement that she had. She'd been having for a long time. So the thing is, what are we going to do to treat this patient? Because we know that, for example, the concern was, yes, she's got jaw pain, but one thing is she wanted to know why she's been having moving the jaw like to the side. So what we did is we sent the patient to MRI. So our differential was maybe it could be some other TMJ disorder, myofascial dystonias, Parkinson's, or a psychiatric disorder. So it came out to be that it's oromandible dystonia. So the thing is, in this cases of oromandible dystonia, we don't see many, what do you call it? There is no diagnosis. Well, there is no, okay, this is the golden thing. Okay, you do this, you'll find a case. On these cases, there is no diagnosis. So you have to rule off other stuff before we come to, okay, it could be one of this, what's called oromandible dystonia. So for example, it is a neurologic disorder which causes a momentary spasm of the lips, tongue, and involuntary jaw and opening movements. And it has, first they said it was mainly because of the excess signals coming from the basal ganglia, but right now there are more studies which is pointing towards cerebellum. That's where it's happening. And usually occurs to 40 to 70 years old. They could be different types. It could be primary or secondary. Primary, maybe being idiopathic. They don't know any ideas. Secondary, maybe due to drugs, and maybe due to Parkinsonism. What happens is in these patients, you see a lot of muscle hyperactivity, fatigue of muscles, dysphagia, and all the stuff like that. And let's see, I'm not going to go too much into it. Usually these patients are misdiagnosed. That's the one thing I want to bring it up to. So usually they're misdiagnosed as TMJ disorder or bruxism or myofascial pain because of the fatigue they offer, because of the fatigue of the muscles. Another thing, medically, these people are diagnosed for like Parkinsonism or some psychiatric disorder because they say that these patients are just making things up. So management, what we did over here was after the patient came to us, we made a soft appliance. Soft appliance meaning that it could serve two purposes. One was if we can stop the movement, it'll help her stop the movement. Another thing is if she's opening and grinding her teeth like that, it will help her all the fillings and restorations, the teeth. And after 4 weeks, the patient, we replaced the soft with a hard appliance. And this patient had 40% reduction of the pain, or not only pain, I mean the jaw movements as such. But the only problem is the patient still had the tongue thrust visible. So the patient said that she wanted to go for treatment. So the option was to do neurotoxin, botulinum neurotoxin injections on the muscle. That we didn't do. I think we had to send it to the neurologist, and they had to do that for us. And let's see, what else do we have? I think that's about it. And this is the recent article that was published by, I think, 4.0, I think it's still in press. You could see that how many times the patient had been misdiagnosed. And look at, there was one case that really found that the patient had gone to 12 different dentists before the patient was diagnosed with oromandibular dystonia. The reason I got this is because I think we might have to keep an open mind and look at all the cases and see, for example, I always tell them that as a dentist, we always see a half of the face. When you sit in the chair, you're going to see only one side of the face. You're not going to see the whole patient as such. So always the best way to do a, or like an examination or anything like that is you sit in front and you talk to the patient. So the takeaway is there are other things that might be possible, and always keep an open mind. So that's about it. And go ahead, Dr. Junad.
Junad, you're muted. Dr. Junad, you're muted, so you have to unmute and talk.
Yeah, thank you. So we'll, because of the time, we want to make sure that we can entertain some questions also. And I think I'm reading some questions. There's some quite interesting questions. This is the last case, and we'll go over it very briefly. We had a patient that came to a clinic, 56-year-old Caucasian female. She came and she said basically she has pain on the right side of her face. When we started digging in and started taking the history, she said that 2 years ago, she had a root canal done. And while she was getting the root canal done, she felt like there was a sharp bolt, or she felt like a nerve was cut. We hear all these stories a lot of times if there's inadequate anesthesia, or, if we haven't blocked well, or whatever the process is. Some patients just don't react to an anesthetic. So the procedure was done. She went back, and, a few months later, she started developing the problem again, where she had pain in the tooth, and they did an apicoectomy on tooth number 4, which is the right second premolar. Long story short, 6 months later, she started developing this moderate to severe pain. And right now she was concerned because the frequency of attacks was getting higher. She used to get an attack once or twice, but now she gets it 5 to 8 times a day. It started as a moderate achy pain, but now when she gets the active attack, she reports that the pain is burning in nature. Some of the things that she can recall that aggravate the pain are basically when she goes out in the cold or stress. And she's really stressed because it's a 6-month thing and the pain's not going away. She tried taking over-the-counter medications. They initially help, but she feels like there's no partial relief. And something recently that she started noticing was that the color of her face changes when she gets the attack. And we were fortunate enough that when the patient was here, she had one of those attacks. When we look into the medical history, there's nothing of significance that would, make us wonder that there's something else that needs to be looked at. She did have seasonal allergies. She had thyroiditis, Hashimoto's, but it was basically well controlled with medication. And what she said was that the pain had started to, it started over here up in the oral region where the root canal was done, but then it started spreading out to her arm and shoulder. And she feels that, the territory of this pain is increasing over the last 6 months. We did not find anything significant in the regular exam that all of you guys do. The cranial nerve screening, obviously, when we did light touch in those areas, the patient felt like that, it was more sensitive. And she was more afraid for us to do an exam because she thought that we might be able to initiate the pain. So this is a picture of the patient when the patient was there. We took, air and we just blowed it gently over the cheek area. And in picture B, you can see there was no autonomic feature, but the minute we did that, this is the presentation of the patient when it came, it started turning into red, and her face was all blushed too. She didn't want us to take pictures of her face, but this is what happened. Any ideas of where you think this might be falling under what category? For the purpose of this presentation, where we're trying to limit it to musculoskeletal, neurovascular, neuropathic. I think, from the last few cases, you can think it's definitely not a tooth problem. But when we did and completed our exam, what it came up to was complex regional pain syndrome. This is something somebody had asked a question about phantom pain also. It's probably one of those things. It was, you know, two types of it, CRIPS type 1 and CRIPS type 2. Type 2 is when there's a major nerve injury going on. It's also known as causalgia. CRIPS type 1 is where most of the dental things fall in. There's either minor injury, there's a debate on whether it has to be nerve injury or not. If you look at the old data, it recommends or suggests that fractures, sprains can initiate that. The literature on the fact that dentistry causing CRIPS is very limited, but there are reports out there, there's reviews out there showing that CRIPS can be basically initiated by a minor nerve damage, which could be secondary to a root canal. And this is what the case is. When we look at it, females have a higher prevalence, and the mean age is anywhere from 37 to 60 with the median of 42. The thing over here that's important is that a lot of the clinical features that the patients present with are those that are presented in patients with neuropathic pain also. For example, allodynia. It is present almost in 75% of the patients, which is a very big number. Color changes, temperature asymmetry, edema. These all signs and symptomology are present not only in CRIPS, but in neuropathic pain too. The difference for the most part is that the autonomic nervous system now is involved. When there's changes in the way the skin is, temperature changes, the autonomic nervous system has kicked in. And at this point, we can basically differentiate if it's a pure neuropathic pain condition or if there is an involvement of the sympathetic nervous system at this point in it. There's a bunch of reasons to why CRIPS happen. And I can, you know, at least there's no conclusion to this is the sole reason. Some of the main things are that there's increased neuroinflammation. There's increase in glutamate in the spinal cord level, which is an excitatory neurotransmitter. Increase in pro-inflammatory cytokines, substance P and CGRP, which are probably the hallmark of neurogenic inflammation itself. An alteration in the sympathetic nervous system, like I had mentioned, some people blame it on autoimmune disease. They've seen that there are immunoglobulin G autoantibodies in the neurons itself, and they claim that there's something going on, genetics. But, you know, if you just summarize it, the three most important things that where there's a general consensus is that it's either inflammatory, this inflammation stays for long enough, 3 to 6 months, and gets the sympathetic nervous system involved. And once this happens and it's not treated early on, there are changes in the way the brain is wired, which is known as cortical changes or neuroplastic changes. And that basically maintains the pain. There is no definitive test to basically diagnose CRIPS itself. The blood work can be done, and you're basically going to try to rule out different type of infections or anything else going on, any autoimmune disease which could be underlying cause for that. Sometimes people do order ultrasounds, and the reason why is to see if it's a vascular problem. Patients who have this, you know, throughout the body will have swelling, redness, and you want to make sure it's not a blockage or anything, or there's nothing else going on in terms of the central nervous system being involved. Imaging is done in advanced cases, but the idea is not to rule out CRIPS, but it's to see if there's osteoporosis of the bone itself. Pretty much you exclude everything out, and that is when you come to your diagnosis of CRIPS. In dentistry, the prevalence is very low because majority of the cases of CRIPS will involve some major nerve damage, which comes to CRIPS type 2, like we had mentioned in the start. So when the patient does come, the differential, you know, neuropathic pain is something which obviously comes to mind as the nerve is involved, vascular disease, inflammation, myofascial pain sometimes, or sympathetically maintained pain secondary to trauma. And all these things are, you know, in the same vicinity as that of CRIPS. When we talk about management, obviously a medical professional will treat this, you know, with the help of an interdisciplinary approach. But I think one of the things a dentist can do is, number one, is not only to recognize it, but the successful treatment is giving sympathetic blocks. You want to go and block the autonomic nervous system, especially the sympathetic aspect of it, to basically reduce all the autonomic features that the patient is experiencing. And in our case, we basically send the patient either to an oral surgeon or anesthesiologist that will do a stellate ganglion block. And in this case too, we did it twice. At an interval of 15 days, the patient got 2 blocks and her pain actually reduced after 4 months to almost 0. Again, something where we cannot directly help the patient, but this patient was at least in the system for a good year or 2 before she got to someone to figure out what exactly is going. I'll stop at this. I mean, you know, there's way too much to go over, but I think we will entertain some questions right now because there are some very good questions. And Dr. Dinesh, is there something specific you would like for us to go through, or should we just randomly pick questions?
Dr. Junad, you can pick up questions. I mean, just avoid overlapping questions, and something which is not covered in the part of your presentation, you could cover those questions as well. Okay.
So let's start with Sampant over here. With adequate analgesics, some patients may experience post-operative pain, and it may be due to patients' emotional distress. How do you manage those patients psychologically? I'm not trained to manage a patient psychologically. I can tell you that. What I can do is I can refer the patient, I can identify the problem, and I can work with the person who's going to treat this patient. Like I said, when it comes to Access 2, there's questionnaires, very brief. It takes less than 5 minutes. Yes, no questions. It's probably the first tool to use for these patients, and then have a relationship with mental health providers, with neurologists, with rheumatologists, with ENT doctors, and you refer those patients to them back and forth. So you do have to work with other people. Most of the traditional pain medications that we use for chronic pain are not analgesics. They're either antidepressants or antiepileptics, but we use them on a subclinical dose in a clinical setting to treat these patients. So if you can use a dose for depression with the help of a mental health provider and treat the pain, it kind of serves the purpose for everyone. So you need to have an approach where you involve everyone. How do you rule out atypical neuralgia? What can be presenting symptoms?
Dr. Junad, I can read out the questions if you want to.
Sure, I'm okay either ways.
Okay, right. So yeah, so I'll go by order. So there is a problem-based question by Professor Dr. Karthikeyan Ramalingam. He is one old pal of Dr. Robby. He says hi to you, Robby. And he says he has a 34-year-old female patient complaining of left-sided headache in the frontal and temporal region. It is sometimes pulsatile and sometimes has pain in the inner ear. Since 15 days, she has developed swelling and drooping of the left upper eyelid. She is under propranolol, sodium valproate, and multivitamins as diagnosed with migraine or sinusitis in a private setup. So he just needs what could be the differential diagnosis and the mode of managing her pain.
I don't know what the differential diagnosis is. I can tell you that these are not good signs. The first thing I would do for this patient is get an MRI. Because if you look at the age group, you know, that always is something that you want to make sure. Anybody below the age of 45, new progressive headache, drooping of the eyelid, anything like that, even if it's a new migraine, you want to make sure there's nothing of the central aspect involved in it. The medications are fine. There's no question about it. But is it palsy? Is it a lower motor or upper motor lesion? Is it something central? Is it MS? Is it CPA angle tumor? Is it an infection? Is it an autoimmune thing going on? It could be a bunch of things. But I think the first thing is to make sure you do an MRI of the brainstem. Make sure there's nothing centrally going on. Everything else we can manage, we can treat. But if there's something central, we want to make sure we're not wasting time. A lot of times patients will have aneurysms, and that's just a ticking bomb. So, you know, the presentation over here is something where it warrants an MRI.
Thank you, Junad. There is another question from Dr. Karthik Raman. Can a mental nerve anesthesia lead to neuropathic pain? I have a patient who had an emergency root canal done 2 weeks ago. Her pain went down, but now she is left with paresthesia and pain with a lower lift on the left side. So what could be the reason for this?
It can cause neuropathic pain. Usually it's not as common, I'll put it that way. we go in with our needle, we have to really damage a nerve. We have to really fight a nerve to cause neuropathic pain. If the pain is, I would do some sort of QST on this patient to see that if there is any hope of nerve regeneration or not. The first 3 months are critical in these patients. That's when the maximum nerve regeneration and sensory alteration will come back. 2 ways to go about this is that, number one, you do steroids. You start that for a week or 2, see how that reacts. If that doesn't happen, typically what we do is we will start the patient on a TCA or an antidepressant. Amitriptyline is something that you can prescribe to this patient, or duloxetine. These medications are approved for neuropathic pain and neuropathies. Not only that, there are reports showing that they basically facilitate orofacial nerve regeneration in neuropathic pain conditions. But monitoring this patient and doing some sort of QST is very important.
Yep, thanks, Junad. And there is another question from Suchitra Sampath Kumar. With adequate analgesics, some patients may experience post-operative pain, and it may be due to patients' emotional distress. How do you manage these patients psychologically?
I think I went through this question first. That was the first one I answered.
Okay, sorry about that. So I think that was covered. Okay. So there is another doctor who has asked a question about relating to his patient in his clinic, a male patient, 40 years old, with prolonged unspecified pain in his right lower face, which is unilateral, and it was felt a year ago. And until his third molar and second premolar was extracted because of the teeth suspected as pain source. But he says after the extraction of the tooth, no significant change in his pain. He describes the pain like electrocuted and like pulled out from the anterior region to the posterior. There is no idea about his pain, and the panoramic radiograph didn't show any abnormal things. So I just wants to know what could be this.
So one of the first things is that, we try not to classify facial pain as atypical facial pain when we have no answers. And that is something which we see all the time when we get a referral from a neurologist or ENT saying that please treat or look at the atypical pain for TMJ disorders or whatever we do. I think if we look at the new and recent guidelines and classification, it falls into some sort of category somewhere. The umbrella term is now referred to as painful post-traumatic trigeminal neuropathy or injuries. And if you look at the ISP guidelines, or there's a book, out there with all the guidelines, we can see that there's some sort of place for these conditions. Things like these, the history that you're presenting, there's something that was back in the day known as atypical odontalgia. And what happens is a patient will come say, I have pain in my tooth. That's like a pulsing pain, a throbbing pain. And you take an x-ray, you take a PA, you do all your testing, and everything is negative. And you really can't find a cause for the type of presentation the patient is explaining. Many people sometimes will do a root canal just to make sure that the nerve is killed, and maybe there's something, a crack or something which is so small that we can't see. But sometimes they will get a root canal followed by an extraction. The pain will go away for a week or 2 if you do get the dental procedure, but it will come back, and most times, more oftenly, it will migrate to the next tooth. So patients will come and they will have multiple extractions done over the course of 5-6 years trying to treat the pain. Either it localized there or starts moving around. So when it comes to atypical odontalgia, I don't have the full history of the patient. Trileptal is a medication that works very good. We have enough data, at least in the dental world right now, where we can say that what medications will work the best for what kind of conditions. I know we all have at least heard of trigeminal neuralgia and carbamazepine, Tegretol, right? Nobody can deny that. So that's one medication that has been proven with evidence it works the best. And, like I said, don't throw everything under the category of atypical facial pain. But something that you can look up or read about is atypical odontalgia, and you might get some answers.
Okay, thank you, Junad. And there is a question on a role of photobiomodulation therapy in the management of orofacial pain.
So photobiomodulation is something which is getting very popular. It's used in oral mucosal lesions. There are systematic reviews showing that it works for myofascial pain, it works for tinnitus, it works for TMJ disorders, it works for burning mouth syndrome, it works for everything. You know, all these adjunctive therapies that we have out there in chronic pain, like I had mentioned earlier, we have all the options. You know, low laser therapy is one, acupuncture, hypnosis, chiropractor, biofeedback, cognitive behavior, herbs, yoga, meditation. All these things are out there, but it's not always necessary that all these things will work for all the patients. You know, acupuncture might work for you, it might not work for somebody else. You know, meditation might work for me, it might not work for somebody else. So I think it's a good adjunct treatment out there. The evidence is all supporting that it does work. The unfortunate thing is we have no proper protocols. We don't know how much laser to apply, what the energy is, what spot size is, what the frequency is. So how much sessions should we give? How much time should we give it for? But there's enough systematic reviews out there indicating that it's a good treatment option.
Yep. Because we are running short of time, we would just take last two questions. And is there any clinical and diagnostic test for trigeminal neuralgia other than history and nerve block?
Well, you know, your history probably, yes. What you can do is you want to identify if the first of all, you want to identify if the trigeminal is central or if there's a peripheral problem to it. You want to make sure it's not coming from a brain tumor or something else. You want to make sure it's a compression of the middle cerebral, and that's what the reason is. The second thing is you look for trigger zones. If the patient has intraoral trigger zones, they will be, you can stimulate them with light touch. So A beta fibers, like I said, which don't take and transmit pain, when you take your light touch and swab it outside or internally where they brush, it will start stimulating pain. So there's two ways to do it. One is you apply topical over there, you numb the area, and then you apply your light touch again to see if the pain goes away or not. That will help you understand if it's a localized problem or if it's a central problem. The second thing is that when you stimulate that area and the patient gets the attack, there's a refractory period. If you take your stimulus and you retry to apply it again within the first minute or two, the patient will not get an attack because you've generated an action potential and it goes through polarization and hyperpolarization. So immediately, if you try to provoke the area again in the trigger zone, the patient is not going to feel the pain. So that will give you an idea of what it is. Again, there's no magic test like, you know, you do this and you've confirmed, but you'll have to play around with different kind of testing and figure out what's going on.
Yep. So thank you. And there is a career-based question from Dr. Purni Murli, an intern. She asks, should I have to finish DDS to do masters in orofacial pain? She's asking, should I have to clear the National Board Dental Examinations to get into this course?
So every university has a different requirement. You know, all postgraduate programs are open to international students at Eastman. Majority of the residency programs, our program is. You don't have to take the boards. You don't have to do, as long as you have a BDS, I think you're good. You should be okay. It gets competitive, I can tell you that. There's some outstanding students that come from all around the world. So I think at least the committee is looking for somebody as a whole candidate, not only academic qualifications. But yes, you are, and you can apply.
Yep. And this final question, so this question is going to take a little bit of time for you to complete. So this is the entire sum up of the entire presentation. So is there,
it's 9 o'clock.
What is the diagnostic protocol for orofacial pain, and how are we going to start, and any prognostic and diagnostic method at present?
I think this is a whole lecture itself.
Yeah,
it
I understood. So I thought that we'll complete the session with this question. So it sums up the entire presentation.
Yeah, I think the 7 magic questions are the same for anything. What's the onset? You want to understand if it was traumatic or it started by itself. If it's spontaneous and there's no underlying cause for it, you need to start thinking, okay, what can trigger a pain just by itself? If it's trauma related, you know there's a cause for it. After onset, you want to go to the location of the pain, then duration, intensity, frequency, associating factors, alleviating factors, autonomic factors. Does it wake you up from sleep? Do you have any headache disorders? Once you have these 8, 9 questions, I think by the end of it, you can at least start thinking where to branch out. Is it a myofascial component? Is it a neuropathic component? Is it a cranial lesion component? Is it a neurovascular component? And then you do your diagnostic testing or your clinical exam to support what you think it is. I think it's very extremely rare to have a chronic pain, orofacial pain patient that comes with one complaint. You know, my mentor used to tell me that once you turn 40 and nothing hurts, make sure you're alive. So as we age, you know, there's always some sort of pain or ache or something going on. And we live with it, but usually patients will come when it gets to a level which is unbearable. So while you're taking the history, you need to be thinking of 2 or 3 different diagnoses and 2 or 3 different areas that you think the patient might be experiencing. And the reason why that's important is because you want to dissect each problem and treat each problem individually. If you don't do that and you try to do one umbrella treatment for everything, it's not going to work. Majority of the times, when I speak or I go out and I meet with different dentists and all that, the concept of TMJ disorders usually ends up with an appliance. You have myofascial pain, you grind, you clench, you have a disc disorder, throw in an appliance, right? And that's what it is. And that's what I learned when I was in dental school. I'm a little older, but yeah, that was what the mindset we had. But, you know, if you look at all the data, appliances have nothing to do with TMJ. I don't think there's any study or any data showing that appliance is the best thing for myofascial pain. Appliance is the best for clenching. Is that true? I don't think that's true. We're basically treating things around the initial cause, but we want to look into more detail to what it is. Majority of patients will have fibromyalgia, and they come with trigger points. We're treating, we're giving injections, we're giving muscle relaxants. They're not working, and we're just not thinking outside of the box. Majority of patients will have disc disorders, you know, deviation, deflection. We'll just throw in a joint stabilizing appliance, but we don't know what we're looking at. We want to make sure there's no retrodiscal inflammation going on. We want to make sure if the disc is reduced or not reduced. We want to make sure we're looking at the thing we're treating at. There's 4, 5, 6 different type of appliances. You could have a joint stabilizing appliance, anterior repositioning appliance. You could have a soft guard. You could have a night guard, whatever you want to call it. And they're all used for different purposes. And, you know, finally, I always tell my patients, at least is when they come, is that I don't want you to take an appliance and wear it for the rest of your life. You know, if you break your leg, God forbid, you're not going to wear a brace for the rest of your life, right? So if somebody's coming with a TMJ problem, you really don't want them to be hooked up on an appliance for the rest of their life. As long as you can treat the underlying problem, you should be okay and then wean off. Some patients do need a night guard kind of thing just for the fact that they grind and clench so much that they're wearing their tooth off. But other than that, I don't see any purpose. The most simplest thing that when you're really confused is a diagnostic block. And we tell our residents over here, it's something we do on an everyday basis in our clinics. You have a problem, you see nothing in the x-ray, the tooth looks okay, you don't see any, maybe there's some superficial caries, but the intensity of pain is not matching. Block the tooth, block the nerve, give a local infiltration. That should kill all the pain, right? If it does, you know the problem is local. It has to be somewhere. Maybe it's not the tooth, maybe it's the ligament, something, a supporting structure. It's local. But if you, I'm pretty confident all of us that have been practicing dentistry for a year or two are very good at giving a local infiltration. We know when we did it wrong. So if you give it and the pain still doesn't go away, stop. If the x-ray is good, stop. And start thinking outside of the box. Maybe there's a problem somewhere else going on.
Okay, thank you, Junad. Thank you, Junad, for that extensive explanation. And to conclude, finally, there is a note from Dr. Soundarya Srinivasan from King's London College. So she wants to thank Dr. George, Dr. Shilpa, and Dr. Junad for your excellent explanation and presentations of the cases. So thank you very much, Junad. And she has just dropped in a note from her side. And first of all, I should thank all 3 of you for having taken my invitation to do such a wonderful presentation. And like Dr. Shilpa mentioned, As dentists, we are obsessed with tooth. For any orofacial pain, we cite tooth as a region. So I've just opened our eyes to think out of the box for other causes of the orofacial pain. So I would like to hand over to Dr. Nandini for the Thanksgiving. Dr. Nandini, you are muted. Please unmute.
Good evening to one and all. Just start off with a quote. Just as one candle lights another and can light thousands of other lights, so can one heart illuminate another heart and can illuminate thousands of other hearts. With this in mind, I just want to give a vote of thanks. On behalf of the Department of Oral Pathology, SRM Dental College Ramapuram, I, Dr. Nandini, extend my heartfelt thanks to our eminent speakers, Dr. Junad Khan, Dr. Robby George, and Dr. Shilpa Singh. Superficially seen, this topic seems to be a typical term of medicine, like the tip of the iceberg. But it is a well-known fact that to understand any concept of medicine in its entirety, one must learn to decipher the pathology behind it. The infinite field of oral pathology spreads its tentacles far and wide and doesn't spare any field of medicine without leaving a brazen stamp of its own. So it plays an important role in the depths of the disease to understand its etiology and in its summit to find the cure for the same. To decode the oral facial concept of oral facial pain to its fullest glory, it is crucial to appreciate the physiology, pathology, medicine, and the treatment behind it, which our distinguished speakers accomplished proficiently tonight. I once again extend my sincere thanks to Dr. Junad Khan, Dr. Robby George, and Dr. Shilpa Singh for an enthralling webinar. Now, the e-certificates will be given to our speakers, Dr. Junad Khan, Dr. Robby George, and Dr. Shilpa Singh. Thank you to one and all.
So thank you panelists for your wonderful enlightening. And with your permission, we are going to share your email IDs to our attendees. So if there is anything they could ask you in future, so they would be contacting you. So thank you, Junad, for having readily accepted, and thanks, Robby, my dear friend, for almost 20 years. We have done a lot of things together, and we have done one webinar together.
There are certain things in life I want to forget. Okay, thank you, Dinesh.
Okay, and Dr. Shilpa, thank you very much for your presence, and thank you for your presentation. And with this, we would close this session. And for the participants, we have posted the link for the feedback form. You could fill in the feedback form, and you would receive your e-certificates within a few days. Thank you very much for all your presence here. Thank you, and bye, guys.
Thank you. Good night.
Yeah, bye-bye. Good night. Bye.